Good evening, everybody. Thank you for joining us today to attend our 5th event of the Lipedema Awareness Month, the extended version that is organized and offered by our association and Lympha, Lipedema UK and Lipedema Italia. We would like to thank all the people who are appreciating our initiatives and flooding us with questions and asking for more events like this in the future. So thank you very much.
Oh, I have the problem now. I've got the translation on my ear.
Okay,
Oh,
so
what
can
did I
you
do
just stop now for a second and solve these issues, please? Because Dr. Ilka is hearing the translation in her
Well, now I can't hear
headphones.
anything anymore. Sorry.
Don't worry,
What's wrong now?
We always have some technical issues, but it's the best way to solve them is on the spot. So sorry for the interruption. Just tell us when it's okay. It's okay now? Do you hear the translation again? Okay. So let me just conclude the introduction, and then we should take a little break to solve the problem in the microphone of the doctor, okay?
Okay, now I can hear you again. Did I do anything wrong? Because suddenly it switched from your English to Spanish or Italian.
Yeah, I just asked the technical staff to solve this issue, please, because the
okay, now I can hear you again. Yeah.
Oh, okay, perfect.
Yeah, you're good again, Valeria. It's because we've been so ambitious in streaming on multiple platforms and multiple languages, we sometimes have a few moments where the language that we're in and the language that we want our audience to hear doesn't always sync up. So apologies.
Okay, so I just keep on smiling, but I'm listening now.
Smile, you're good.
Don't worry, if we have any technical problem, we will share the video with all the technical issues solved. So don't worry, and let's enjoy this live. Because now I know that it's not June anymore, it's July. And so, but we decided together to raise attention and awareness on lipedema, also in other time of the year, because including the month of July, that generally appears quite silent in for the attention on lipedema after all the attention we generally manage to raise in the month of June that is dedicated to lipedema awareness. So please stay with us. Sorry for any technical issue forward. And let me just give just 1 second to invite all the representatives of Lipedema Association worldwide to join our Facebook advocacy page for people with lipedema, and please send us your statement and pictures, because they are very inspiring for other patients to take good care of themselves. So let's get right into the event. So let me just thank our precious donors who made all of this possible: Human Med, Uzo Italia, Vari Sanci Z Medicali, Solidia, and Medi UK. Thank you very much. Let's introduce finally our guest from Hansa-Klinik in Germany, which is one of the leading clinics for liposuction and specialized in the treatment of lipedema since maybe 2001, if I'm not wrong. Mm-hmm. So Kate, would you mind?
Thank you, Valeria. And as Valeria says, Dr. Mira Vollrath, or Dr. Ilka, as she's kindly said we can call her tonight, thank you so much for making the time to join us. The work that's done at the Hansa-Klinik and the publications that you all have are some of the ones that have been leading the way for many of us in the lipedema community. So I'm certainly very excited to have the opportunity to meet you. As Valeria says, the Hansa-Klinik was treating lipedema in 2001, 2002, which is when you joined the Hansa-Klinik yourself, working with Professor Schmeller, who many of us know and love. And so to have the opportunity to hear from someone who spent over 10 years performing lipedema liposuction, who has published many different publications with your colleagues on aspects of lipedema and liposuction, and who also has the qualifications that you have in dermatology, is a great opportunity for us. So I'm delighted that you came back to the Hansa-Klinik and came back to all of us in lipedema. It's definitely our gain, and certainly personally, when I was looking at having liposuction, your paper with Professor Schmeller and some of your early results were some of the first ones I read. It gave me a lot of confidence. So I know that you'll do that tonight for so many of the other women who are here. And there's so much that I would love to say about everything you've published and everything you've done. But I can just say thank you so much for sparing the time, and the floor is yours, Dr. Ilka.
Well, thank you very much. It's my pleasure to be part of all this, and I'm really happy to be able to talk about our experiences. Yeah. Okay, so I'll start, and I hope it's going to work. Yes. I'm not going to do it wrong.
If you have any problem, please stop, and the technician will help you in this. So don't worry. Enjoy.
And we'll be back with the questions shortly after your presentation. So everybody, please post in all the socials. We're here to catch your feedback. So
okay, can I just check? Can you see my presentation now? Is it okay? Because I can't see you anymore because I've only got one window. Is it okay? Can you see my first picture?
Not yet. Could you try to screen share again, please?
Okay, wait. Why isn't this working now?
That's okay. Our technical team are here, so we'll catch it in a minute.
Wait, let me do it this way, and perhaps it will work this way. Wait, just a second. Sorry.
Perfect. There we go.
Is it now? Okay.
It is. You're perfect. And
thank you.
On the other side.
Good. Well, I'm really happy to be here and to be part of this this whole session you are doing. And as Kate has already said, we've been treating lipedema patients now for over 20 years, and we've got quite an experience. But this doesn't keep us from always moving on and still being critical, so we can really be honest and see what we can do with the surgery and what perhaps we can't. I would like to start with a few overall subjects on lipedema. I know that you all are experts, but still I would like to stress a few points, perhaps to make it more clear why lipedema is what it is and how it develops and what the cause during life is. Just to clarify the definitions, because I know, like Dr. Corneli, he has a different term he uses. We still use lipedema. So it is a localized increase of fat tissue, and important is it makes complaints. On the contrast, the lipohypertrophy can look fairly the same. It's also an increase of fat volume, mainly on the lower legs, but it never is painful, so it doesn't make complaints. We don't need any apparative devices to make the diagnosis of lipedema. You can make the diagnosis just by carefully looking at the patient, by touching the tissue, and by asking him how was the cause and what complaints does it make. So when we look at a patient, we look at is there a disproportion? We look, how is the distribution pattern of the fat? How much fat is there? What is the texture of the fat tissue? What is the texture of the skin? And we also see, does she have complaints? It can be spontaneous pain. It can be pain to pressure. This we can, of course, see when we touch the tissue. Lipedema can really vary between individuals. So it can be that it's hardly visible to, and it can be clearly visible even for someone who's not has had a lot to do with lipedema before. Sometimes we can see fairly strong edema, but our experience is that most of the patients we see, they don't have that strong edema. Also, the easy bruising is a symptom we can see. Patients suffering from lipedema have not only the complaints, but they really have a lot of restrictions in everyday life. And of course, this is due also to the painfulness of the tissue, but also the fat volume as such really restricts you. It's the size of the legs. So women have problems to sit in a chair. The pressure of the chair on the outside of the thighs is not easy to stand, and sometimes they don't fit in. And I've heard so many women saying it's so embarrassing if I sit in a chair with some armrests on the side and then you get up and everyone is looking because you pull the chair up with you. So it's sometimes really just everyday life where there are clear restrictions. And due to the increase of the fat volume, the legs are heavy. And you can imagine that walking up and climbing stairs with this heavy legs, it is difficult. So a lot of women say, okay, we have to rest after several stairs. I have to catch our breath and then we can continue. And you can imagine that if in addition to the increase of the fat volume, there's edema, which increases typically during the daytime, the legs get even more heavy in the evening, and it gets more difficult walking around. And for normal things like getting a pair of shoes and wearing shoes or boots can really become a problem if the increase of fat volume goes down to the ankle. Lower shoes is sometimes possible, but boots or ankle high boots, it really is a problem to find shoes for the winter time. So we see a lot of patients who say, okay, I'm really glad if it's summer because I don't need any higher boots. So these are really just problems women with lipedema may have during everyday life. Also in everyday work, there are restrictions. Just to show you two examples, this young woman is a dental chairside assistant, and you can imagine that with this big increase of volume of the upper arms, which really makes the arms heavy, she said it is really difficult. She can't sit and work longer than 20 minutes because always holding these arms up and not starting to shiver and to move is difficult. So this is why she is now more sitting on the telephone and not working at chairside anymore. Also here, the example of a nursery school teacher who says, okay, we do so many things down on the ground with the small kids, and it's difficult for her to kneel down, to sit on the ground. And then she says, if she's sitting on the ground, she sometimes can't get up. And of course, the legs hurt. So there may be really in a lot of patients a clear restriction in everyday work. And of course, the cosmetic appearance is something which the women are not happy with. This is a young lady who said, well, I don't feel like getting closer contact to a man because I don't like to show myself, so they're insecure. We all know that there are different stages from 1 to 3, and the stages, I always say the staging is just, only covers half of the symptoms of lipedema, because it just deals with the fat volume. Is it smooth? Is it soft? Is it uneven? How is the skin surface? But it doesn't say anything about the complaints. So in a stage 1, there is an increase of fat volume. It can be only merely visible to, you can see it. The skin texture is smooth. There are no nodules if you feel the tissue. In stage 2, the fat volume is more increased. The skin is uneven. And if you feel the tissue, you may have like nodules underneath. And of course, in a stage 3, there's even a bigger increase of fat volume. But the amount of fat doesn't go parallel to the amount of complaints. So we really can have women, if I go back to the stage 1 pictures, like this woman or this woman can have more sensitivity to pressure than one of these. Of course, the disease is more visible for people who look from the outside in these stages, but also these patients can have really strong pain, and it doesn't go parallel to the amount of the fat volume. So this staging only covers really, well, a part of the disease. We know that genetics play a big role in lipedema. So we sometimes or quite often see that there's a family history, like here, mother and 2 daughters. And it is interesting that if mother and daughters are all afflicted, the daughters often have the same proportion of fat and the same body proportion than the mother has. We know that hormones play a crucial role in the development of the symptoms and in the becoming visible of the disease. So people say that before puberty they were slim, and then with puberty the changes started and they gradually increased. So here, this woman at the age of 33 has a clear increase of fat volume and she has complaints. So hormones play a crucial role and are important for the coming out or becoming visible of the disease. And it also can be that later on during lifetime, hormones play a role for changes of the disease. This was a young woman who came to our clinic in 2017. She didn't have any complaints. She just didn't like the look of her legs, thought the volume was too much, and she asked if it would be possible to do something. She didn't decide to have surgery at this time point, but then 3 years later, she came after she gave birth to a child, and she told us that since pregnancy, the fat volume of the legs had clearly increased, and for the first time she had pain in the legs and also in the upper arms. So the changes, the hormonal changes during pregnancy and breastfeeding time led to the becoming visible and to the development of the complaints of lipedema. This is something which can happen or may happen. We also have several patients who say, okay, during pregnancy, there were no changes, but it is, of course, a possibility. And also, we women all will, at a certain age, get into menopause, and this is a time where a lot changes in our body. The hormonal changes, that means the lesser production of estrogen and progesterone, leads as such already to an increased fluid accumulation in the tissue. And also our metabolism decelerates. So that means that less calories are sufficient to gain more weight. So nearly all women increase weight during menopause. So the general body weight can increase, but also the fat volumes of the lipedema may increase, and also the complaints. And this woman said, yes, she already had for a longer time lipedema complaints, but with the menopause and with the increase of the general weight, also the fat volume of the legs increased, and also the painfulness. So this are normal changes of us women during lifetime, and especially these hormonal changes have an impact on lipedema. This is a typical, well, onset or cause of lipedema. A young patient, age 17, came in with her mother to us. She didn't have any complaints. She had no swelling. Then 2 years later, she had already developed a bit of a pain due to pressure. And you can see that there was already a slight increase of the fat volume. And 4 years later, at the age of 23, the fat volume was a bit more. The pain to pressure had increased and there was a slight swelling. So this is quite a typical, well, cause and onset, that it slowly starts and then it gets a bit more. In some patients, it just stays this way, and it doesn't get any worse. But normal is that due to the normal changes of our bodies during getting older, of course, there are always slight changes. It is physiological that we women gain weight about 3 to 4 kilos every 7 to 10 years. So there is, of course, a changing and a getting more of total volume during lifetime. In the last years, there's been a big discussion. Is there a real progression of in lipedema? Of course, some people just, well, it gets a bit more during lifetime, parallel to the increase of the body weight. But in some patients, there is a clear progression. And progression means a really increase of fat volume and an increase of complaints. And this lady who came to our clinic, she brought us a picture of herself at the age of 14, where you can already see that there's a slight increase of fat volume. But of course, during the next 40 years, it has clearly progressed, and there is now a massive increase of fat and also complaints. What we know is that adiposity and our body weight has an influence on lipedema. This patient came 2019, and I saw her 1 year later, and unfortunately, she had gained 20 kilos of weight. And I compared the measurements just to see, well, where were the changes? As you can see, that the biggest increase of volume is up here on the tummy, so the waistline and over the hips. It was an increase of 15 centimeters of circumference. But also this increase of total body weight of 20 kilos also has an impact on the legs. So they have increased in size and volume. And you can also see that just by gaining weight, the texture of the skin has changed. It has become a bit more uneven. Her complaints were just a little bit stronger, but not very much. But we must say, total body weight has an effect on lipedema. A further example, she gained 25 kilos of weight over 3 years. And also here you can see in the waist and the hips is the biggest increase, but there's also an increase of volume at the legs. And if women with lipedema really gain massively weight, and this is a lady with really a massive adiposity, obesity of the trunk, then this also has a strong impact on the legs. Due to this big volume here on the tummy, she developed a lymphedema. You can see that there's a pitting edema on the lower leg and also here on the foot. And this finding was already after 3 weeks of an inpatient treatment with intensive lymphatic drainage. So you can imagine what she must have looked like before these 3 weeks. So she has, in addition to her lipedema, which she had since her first pregnancy, she has an adiposity lymphedema. So additional obesity has a negative impact on the legs, and the swelling can become much stronger. So what can we offer the patients who suffer from lipedema? I think what every person has heard before is, well, just lose weight. And this is the big question mark. Does weight loss have an impact on lipedema, on the fat volume, and can you change the complaints just by losing weight? In a case like this, a woman 31 years old with a lipedema on the of the legs, who has a massive morbid obesity on the trunk, of course, she has to lose weight. She has to find a way with diets and changing her living and eating habits. And if all this doesn't work, then sometimes bariatric surgery can really be an option for a patient like this. But here it is really important. She has to lose weight. And we unfortunately couldn't offer her any surgical therapy for the legs because it is not possible if there's such a huge obesity on the trunk. But what changes if patients with lipedema lose weight? This patient managed to lose 8 kilos of general body weight. And this you could see on the measurements. So as expected, she lost more on the upper part of her body, so around the waist and the hips. She lost 6 to 8 centimeters, but also the weight loss had an effect on the legs. So there was a clear reduction of the volume. She self said, yes, the legs are a bit lighter. She noticed it when walking around. It was easier, but still the tenderness of the tissue and the pain due to pressure still remained the same. Okay, you can say perhaps 8 kilos weight loss is not enough to change the complaints completely. So here an example of a lady who managed to lose 32 kilos. And here again, you can see the biggest loss of circumference was on the tummy and the hips, but also there was a reduction on the volumes of the legs. And as you can see, the legs are slimmer, and also the swelling, which you can here see the impression of the socks, was also a bit less. And she said, yes, it's much easier. I can walk better. The legs are lighter, but also she still had a pain due to pressure. This, I must honestly say, is not in all patients the case. We have some who manage to lose weight and they say, yes, also the sensitivity to pressure is less, but we have not seen one patient who was able to lose or to get rid of the complaints completely just by losing weight. It is, of course, it gives a relief and it makes the legs it reduces the legs in size and it can reduce the heaviness, but it doesn't have this strong impact on reduction in terms of reduction of pain. Just to show you some numbers of here in Germany. In Germany, half of the women are overweight and 24% of the women are massively overweight. That means obese, adipose. But in lipedema in Germany, lipedema patients over 50% are adipose. So it is really an issue in lipedema patients. There is a higher percentage of overweight or adipose patients than in the total population. Why this is the case? No one, I think, can really tell. You can just speculate on why. Is it because of the pain and the heaviness of the legs? You can't move around properly. You do less workout. You do less exercises. And of course, it is frustrating if you do lose some weight and it doesn't show on the legs. It just shows on the upper part, and you get slimmer in the face and you lose your volume on the breast. It really doesn't make you any more happy. Or is there perhaps also some genetical predisposition, or is it everything together? So this is just speculation, but fact is there is an additional adipose problem in the lipedema patients. So over 50%, and this is clearly double amount of as in the normal population, have an additional adiposity. So it is, for these overweight and adipose patients, it is really necessary to find a way to deal with this overweight. And there is not, a lot of patients always ask, well, is there any optimal diet for me as a lipedema patient? No, I can just report on what some patients told me what helped, like Weight Watcher, part-time fasting, or reduction of carbohydrates. I also have a very few patients who underwent a ketogenic diet. This, I think, is really critical because this is such an unnormal nutrition. I think it can't be good to do this on a long term, but these 3 patients who did it, they said they felt better doing it and they lost some weight. But what really is important, because it is a big problem in for lipedema patients, it has to be something which is feasible really in everyday life, and it's generally required long term. So it is something you really have to face, and you have to find a way to to work against it. And it's always better to slowly reduce your weight than any crash diet where it goes down, because usually you can't keep it then and the weight will increase again. And often it is really necessary to get a professional support because just by yourself, it's sometimes a problem to find the right way. And what should be avoided is a yo-yo effect. That means gaining weight, gaining weight again, and losing again. Because a study, and this is really interesting, showed that if women gain weight, lose weight, gain weight, lose weight again, um, it showed that the weight regain led to a higher regain in adipose tissue of the extremities in comparison to the trunk. So if you imagine a lipedema patient, gaining weight, losing weight, gaining weight again, and doing this several times, she will always put a little, or there will come an extra amount of fat will be put on the legs again. So this is an effect we really don't want. So this yo-yo effect should be avoided. And I always give my patients the recommendation, well, perhaps try not to lose too much weight, try to reduce it to a certain level, and which you can then keep stable, because it's not worth going down too low and then not being able to hold it, and then you increase again. So rather, well, not so low, but then try to keep it stable over the lifetime. But it's something these people have to face for the rest of their life. They have to cope with. First line therapy for lipedema is, of course, the conservative therapy. And if the increase of fat volume and the pain in the legs or arms is the main issue and the edema is not so strong, then you start with the compression garment, and of course you have to exercise and move with the compression garment. If the edema is stronger, then it is the recommendation to first undergo a decongestive therapy and wear the compression. And some of these patients then continue, once or twice a week with manual lymphatic drainage. But this is something we really have to look critically on, because we often see patients who go twice a week to manual lymphatic drainage. And when I ask, well, does it help? What changes? And they say, oh no, well, it's just nice going there. Well, this really doesn't make sense. Manual lymphatic drainage is a good therapeutic option if there's a strong edema. But if it's only a slight swelling during the daytime, it is sufficient to wear compression. And you can also get a lymphatic drainage by exercising in water. So this would be the better option than go to a manual lymphatic drainage twice a week. Why does or what effect does the compression therapy have on the complaints? It stabilizes the tissue, so when moving around, the mechanical irritation of the tissue is reduced. So the shear forces in the tissue is reduced, and this makes the tissue less sensitive to pain. And also it is said that the compression has some sort of inflammatory effect, so also this leads to pain. Because we know that the main reason or the main the cause of the pain is not the edema. What we thought, like, I don't know, 20 years ago, we thought if people have edema in the legs, this makes the legs painful. Now we know there is some sort of inflammatory reactions in the fatty tissue which leads to the pain. And of course, if there's edema in the tissue, then the wearing of the compression garment reduces this edema and therefore leads to a less heaviness and less tension in the tissue. So this helps part of the patients to feel better. They have less pain, less swelling. But we also have a lot of patients who undergo conservative therapy over several years, but they say it doesn't help me enough. Because of course, there's still this increase of fat volume, which makes the legs heavy. This is a lady, she's a midwife, and she says, I wear my flat knitted compression garment regularly every day, but still I'm so restricted in when I'm helping women giving birth. I sometimes have to go down on my knees and I can't get up again. It hurts if someone knocks into my side. So although she is undergoing lymphatic drainage and wearing compression garments, she still has massive problems. This lady wears compression garment and still has persistent pain in the legs and says, this is not the way I want to continue my whole life. And also, there's still the cosmetic impairment due to the increase of the fat volume. And also, we have some patients who have a progression, a real progression, although they are wearing compression garment. So here in over 3 years, there was a clear increase of fat volume and also the complaints, although she was regularly wearing her compression garments. Also here on the lower legs, she even managed in 9 years to lose a little bit of weight. But still, if you compare the circumference of the lower legs to the upper legs, you can see how there's been an increase. There's more fat volume and more complaints, although she was regularly wearing compression. So what can we do, or what can we offer? We can take the fat away by doing a liposuction. Not every person who presents themselves and has a visible disproportion, has a clear increase of fat volume, however, is has an indication for liposuction. She looks, if you just have a first look, yeah, there is an increase of fat. Why can't we just do a liposuction? Because she has a massive edema. So of course she has a lipedema, but she also has an obesity-associated lymphedema, a phlebiedema, and also a medication-induced edema. So this clear is no indication for surgery. She has to undergo conservative therapy. So not every person with an increase of fat volume is suited for surgery. So the first step to achieve a good result of a surgery, to get a happy patient and also a happy surgeon, this already starts on the first presentation during the consultation, because we really have to select what patients are suited for a liposuction. Are there any contraindications due to their general health? We have to examine and evaluate the tissue and have to make a good plan for surgery, because it is not possible to perform surgery in one session on all these areas. So it is, for safety of the patients, it is necessary to limitate each intervention. And so if the whole leg is afflicted, we often need 2 to 3 to 4 surgeries. We have to talk about risks and side effects of the surgery, and we have to really critically estimate the achievable results, because the patient has to know what can we change and what will perhaps be left over, or what are there any restrictions due to the tissue. And we have to give them a realistic long-time prognosis. And we here in our clinic think this consultation is so important, because we really have to critically talk with the patients. We have to be honest and tell them what we can change and what we can't change. And we really disagree with other surgeons who say, oh, you just have to do it in a proper way and you get rid of everything. No, this is really not true, and this is not the case. And this I'll try to show you with a few pictures. What can we achieve and what can't we achieve? So where do we have limitations? Because this is really important for the patient to make the decision: is the surgery what I want, and will the surgery make me happy and lead me to less complaints? There are different techniques for liposuction, and I would just like to tell a few things about the different techniques, because patients always ask, well, what are the differences? The first differences are in the anesthesia. So liposuction can be performed in a pure tumescent local anesthesia, but also a deep analgesic sedation with the patient nearly sleeping or part-time sleeping is possible, and also the general anesthesia where the patient is completely, say, knocked out and is not awake. And also there are different techniques in the liposuction as such. We have the power-assisted liposuction, we have the water jet-assisted liposuction, ultrasound assisted and also laser assisted liposuction. In the tumescent local anesthesia, a big volume of a local anesthetic solution is filled into the tissue. What are the advantages of this kind of anesthesia? First of all, it's the safety, and this really studies and evaluations have shown that a pure tumescent local anesthesia is the safest way to perform a surgery. All severe complications and side effects up to deaths haven't occurred if a surgery was performed in a pure tumescent local anesthesia. Because the patient is mobile, we have a prophylaxis of thrombosis, so the risk of getting a thrombosis is clearly reduced. The intervention is more tissue sparing because the tissue is prepared with the local anesthetic. We have a mobile patient, so he can not only walk around, he can turn around on the surgery table, and we can achieve better cosmetic results because the patient can turn actively. There's less bleeding intraoperative, and it leads to a more rapid recovery of the patient after surgery. Disadvantage is we need a longer time for preparation. So the whole preparation needs, well, 1.5 to 2 hours. And sometimes if we need larger volumes of the solution, it makes sometimes the evaluation a bit more difficult. Deep analgesic sedation or general anesthesia has the advantage it is less time consuming. So you have an anesthetist, he comes, he injects something intravenously, the patient is asleep and you can start. So you don't have this long preparation time. There is no pain because the patient is asleep, and some surgeons say it is an advantage that you don't have to pay so much attention to the patient because he is sleeping. This, I always say, is for me a big disadvantage because it's so nice to talk to the patients during the surgery. The disadvantage of this form of anesthesia is there is definitely a higher risk of complications. This doesn't mean that every surgery which is performed in a general anesthesia leads to some complications, but there is a clear higher risk. And the event of death is possible. People undergoing liposuction and general anesthesia have died. The patient is not mobile, so you can just, well, passively turn him around from back, laying on his back to laying on his tummy, but you could never do a liposuction in a sideward position. It is less tissue sparing because the tissue is not filled up with this big amount of local anesthetic. Sometimes the cosmetic results are not so good, and definitely the patient needs a longer time for recovery after surgery. And if you have to perform several interventions, then it's several anesthesias over a shorter time period, and this, of course, is a stress for the body. The techniques. The power-assisted liposuction is that the cannula vibrates 4,000 times per minute. And this has the advantage that due to this vibration, it is more tissue sparing because you have to imagine the cannula wobbles very quickly through the tissue. So it is more loosened and it is less painful. And we as a surgeon have to put less pressure onto the cannula. So firmer areas are easier to sculpt, and it leads really to a quicker recovery of the patient after surgery. The only disadvantage I really found in literature is that it strains the surgeon's hands. And yes, we also feel it sometimes that the vibration goes onto the hand a little bit and strains it. Another form is the water jet assisted liposuction. It has the advantage that you only need a shorter preparation time. Also here, before you start doing the liposuction, a smaller amount of tumescent solution is injected, but this goes much quicker. And it is tissue sparing because during the liposuction in parallel, a fluid is injected into the tissue, so it's like a hydrodissection. The tissue is loosened, so it's also tissue sparing. But the disadvantage is it is definitely more painful, so you need a deep analgesic sedation or often even a general anesthesia. And because the contact time of the adrenaline which you put into the tissue is shorter, there's stronger bleeding intraoperatively, and this leads to more and longer lasting hematoma. The ultrasound-assisted liposuction really doesn't have a big advantage. It is said that maybe it dissolves the fat a bit more easier, but it has the big disadvantage that it leads often to longer-lasting pain after surgery because it has an irritating effect on the nerve surrounding cells, and it has led to burning or necrosis of the skin, and there are no studies regarding lipedema. So this is not a technique which is really recommended in lipedema. And also the laser-assisted liposuction. There are, due to the laser, thermal effects in the tissue. So this thermal effects leads sometimes to a better tissue retraction. So this may be an advantage for softer tissue, but the disadvantage is there are burning sensations, the patients have prolonged pain, and you definitely have to say that the thermal effect on lymph vessels is not known, and you can't really predict, does the heat in the tissue has perhaps a negative effect on the lymph vessels. So this is a big question mark. We in our clinic perform the liposuction in pure tumescent local anesthesia, and we use the power-assisted liposuction. So we start, first we take pictures from all sides, and then we mark the surgery, the areas we want to perform the liposuction on. The tumescent solution we use is highly diluted, so regarding to the body weight of the patients, we can give quite an amount, and if only smaller amounts are needed, then we can put a higher concentration of lidocaine, which is the local anesthetic, in there. There's adrenaline in the solution, which leads to less bleeding. The filling up goes over a time about, well, 1 to 1.5 hours. And this, yes, is a funny feeling. It is a strange feeling. And some patients say the tissue is a bit sore or tense when the fluid starts to go in. So of course, although it is a local anesthetic, we can give, of course, something for relaxation, which makes it easier for some patients. It is a funny feeling, but after the first few minutes, once you've well felt what it's like, it gets a bit easier. So after we filled it up completely, the patient is mobile, and this is, I always say, it's quite an experience to walk around with his filled up legs. The skin gets white. This is the adrenaline effect, because the adrenaline is quite long in the tissue. The superficial blood vessels really well are pulled together. This is why it bleeds less during surgery. After we filled it up, we put the patients under a warming blanket, and they need to rest for half an hour because it takes half an hour till the whole fluid has spread in the tissue. So this really takes time, but we think it is worthwhile to do this because we have then a mobile patient who can turn around during surgery. He can give us a feedback if everything is okay. If it hurts, we can inject some further local anesthetic, and of course we can give a central working painkiller also. The fat is suctioned out by an under pressure, and at the end we can see how much fat we have taken out. Part of the fluid we filled in, we suction out again. So this you can see down here, and there's a little bit of blood in there. And there's already a leakage out of the tiny incisions during surgery. And because the patient is mobile, at the end of the surgery, he can stand up, and we can have a final look. With him standing up, we can see are both sides symmetric, and if we see no, there's still too much on one side, then we mark this area, we disinfect again, and we can perform a further liposuction. Because there's still leakage of the fluid out of the legs, we wrap our patients in a big amount of absorption material, and over this absorption material we put on a compression garment. The patient stays one night in our clinic, and our nurses change the bandages for 3 times. The good thing is that on the next morning, you can already see a change. The volume has decreased, the skin has already retracted a little bit. So this is the result of outer and inner thighs and knees, 5 liters of fat. There is a bit of a hematoma, but you can already see an improvement. The postoperative cause is that first it leaks. The leakage stops a few days after surgery, so you need to change bandages at home and you have to wear the compression garments. The hematomas will come through to the surface, so you look a bit different in color, but this goes away after already 3 weeks. So what can we change? Just to give you a few examples, what is possible. Here, after 3 liposuctions, the ventral and the dorsal part of the thigh, the upper arms, the lower arms. This was a big lower leg, and the patient is so happy that already on the next morning you can see that the volume has gone. So by reducing the fat volume, we reduce the space between the muscle and the skin. And because there's less space, on the long term, the body can put less fluid in there. So this is why not only the legs get slimmer and the pain reduces because the fat volume is reduced. Also, there's less possibility that fluid goes in there. An example of the lower legs. This was the midwife I showed you at the beginning after liposuction of the hips and the thighs, and it's a clear decrease in volume, and she really was happy she could move around better. She had less pain, and she said what was really great, she could go with her children into a roller coaster. She didn't fit in and she had so much pain squashing herself in. I know this is not the main thing, but she was really happy that also these kind of things were possible again. But of course, and this is very important, that we also have to stress that we have limitations of surgery. This is like one limitation we have. If the tissue is really soft and there is already before surgery excess tissue, we can achieve a retraction of the skin, but it is not possible that all the skin disappears. So this is a case where there's still excess skin, and this I told the patient beforehand, because when you feel the tissue you can see there's so much left, there will be something left over. Some patients are not disturbed by this. They say, okay, I wear a compression garment on top and this holds the soft skin together. It is okay. The volume is less, the pain is gone, so I can live with this. But if someone says, no, this is no cosmetic result I want to live with, then here you would have to, think of doing like a skin tuck, because there's just too much excess skin left over. Of course, the limitations are not always so massive as in the patient beforehand. Sometimes we just have some leftover or remaining softness of the skin here on the outer side. This is not much, but I always show the patients clearly beforehand what can be left over, because this doesn't depend so much on me as a surgeon. It depends more on the tissue. How does it retract? How firm will it be? And we can predict this quite good when feeling the tissue, and we have to talk about this. So if someone says, no, a result like this wouldn't make me happy, then we really have to think, is the liposuction the right thing to do? Also here, a very soft tissue, already hanging over the knee beforehand. The skin retraction is there and is visible, but sometimes like a crease over the knee stays. We sometimes have a chance, if we go in there once more and perform a further liposuction, that we can, make the body retract the skin a little bit more. But in some cases, just this a sort of or a bit amount of crease stays. So these are limitations we have due to the softness and the amount of the tissue. But of course, also the result of the surgery depends on the surgeon as such. And unfortunately, we sometimes see really not nice results where there's been excessive liposuction to superficial liposuction, an unevenness of the skin. This is clear due to the surgeon. This is nothing which has to do with the tissue. This is that someone didn't well perform the liposuction in an even way. And also this young lady was 23 and she had liposuction of the bottom, and the surgeon just took nearly everything away, leading to a necrosis of the skin. And in this case, it is not that the surgeon didn't know what he's doing. He said it's what he says, you have to radically take all the fat away in lipedema to cure the patients. We think this is excessive because it results in an uneven skin. It sometimes results in a necrosis of the skin, and the scarring, which is much stronger, leads of course to an impairment of the lymphatic flow. So we disagree with this surgeon. We say no, this is too radical. This is a further patient where very radically the fat was taken away, and I saw her 6 weeks after her surgery, and the skin was just sticking to the muscle. I couldn't move it at all. It was solid on the inner side. She couldn't really bend her knees. After 6 months, the tissue became a little bit more soft and loose, but the surgeon has taken everything away. So it was just the skin over the muscle, and you could feel and see the veins. And she now had lymphedema on the lower leg. So this definitely shows if you perform the surgery too radically, it ends up in impairing the lymphatic flow, and this is not what we want. We want to keep and save the lymphatic flow because the patients still need it. But also, on the other hand, we sometimes see patients who underwent a liposuction, and she said, yes, well, the legs are slimmer. My jeans don't fit anymore. I had to buy a size smaller, but she still has pain in her legs. So here it was too little volume was reduced, so it didn't have an influence on the pain. This was easy to correct, so we performed a further liposuction. I took an additional amount of fat out. This led to, well, an even smaller leg, and now she was totally free of complaints. So this does show you have to take away quite an amount of fat, but it is still possible to do this with a good cosmetic result. And it doesn't make sense to radically take away everything because this impairs the lymphatic flow and the skin sticks to the muscle, and this is not what we want. We were really curious to see, well, what changes due to surgery? Is this effect long-lasting, and does it really reduce the complaints? So this is why we in the clinic did a study. We asked patients 4 years, 8 years, and then 12 years after surgery how their complaints had changed. So here you see the results. This is the amount always of pain and complaints before surgery. And I have to stress that all the patients we evaluated had already undergone conservative therapy. So they've regularly been wearing compression garments, undergoing lymphatic drainage, and this is still the amount of complaints they had. Spontaneous pain, sensitivity to pressure, bruising, and edema. And this is the effect that we achieved due to the liposuction. So there is clear reduction of the complaints, and this stayed quite the same. In some complaints, there was a slight increase between 4 and 8 years, but then it remained stable till after 12 years. And also the restrictions of movement or cosmetic impairment, there is a change. But what you can clearly say, and this is what we stress, we have some patients who are completely free of complaints, but we also have some who still have some to a lesser degree, but they still have some. And if we add all these complaints together, and this makes sort of overall impairment, you can see that this is the effect we can achieve due to the liposuction. This is the amount of impairment still under conservative therapy, and this reduction is due to the surgery. So the surgery is an option to further reduce complaints. But we disagree with other colleagues who say we can cure lipedema. No, we really can't cure it. We can make it better and we can lessen the complaints. And in some patients, we can get rid of the complaints completely. But in most of them, there's still a slight amount of complaints remain. And this we also see when we ask, well, what do they have to do after liposuction still? 30% don't do anything anymore. No compression, no lymphatic drainage. 60%, so the bigger amount, still does it, but to a lesser extent. And 10% do it in the same way as before surgery, but they say it has a bigger effect now. And these patients always tell us that after surgery, even if they still wear compression, it's much easier to put it on. You can achieve a better fit, and they say you can temporarily leave it out. So in some days you don't have to wear it, but not all can. We can't get rid of the compression totally in all patients after surgery. This is an example of a course over 11 years after surgery. You can see that although there are quite a few changes in total weight, it is a quite stable finding over the time. There's another lady, 13 years after surgery. It remained the same, but I measured her and it was a little bit more, although she only gained like 2 kilos of weight. But this is just due to the normal changes our body undergoes during lifetime. So the result of the of the surgery stays in some way, but it slightly changes over the years. But she had a pregnancy in between and she said it didn't change anything. So this is a very good result still after 13 years. But yes, a slight difference, a slight change is there. But we can't, as we Germans say, we can't turn back time. So there will be still some changes after the surgery. And we have some patients who can't do without compression and lymphatic drainage. She didn't do it anymore after 3 years, and she still had a stronger swelling again. So some still have to keep on wearing their compression garment. Something we sometimes see in patients is that they are able to lose weight suddenly. This patient, 120 kilos before surgery, said, well, I've tried so many diets and I've tried doing exercises. I just couldn't really reduce my weight. I performed liposuction 4 sessions and I removed nearly 25 liters of fat. Unfortunately, 25 liters of fat doesn't equal 25 kilos. This would be really great, but this is not the case. About half of the volume of fat equals to kilos. So about 25 liters of fat means that we've got rid of about 12 to 13 kilos. But she managed to lose 40 kilos. This was her before the last surgery, so we still had to do the front part, and this was really great. And she said, I don't know, I didn't really change anything, but something just changed in my body and it was possible for me to lose the weight. And this is great because part of the result we achieved was due to my work, but also a big part was due to her loss of additional weight. Also, this patient managed to lose after surgery 40 in total 40 kilos with the help of a nutritionist, and I think she used a Peloton and an exercise, but it is possible. So we see that body proportions change after liposuction, weight loss, and spots. The change of the legs was due to my surgery, but the change of the tummy up here, she managed to do. And she said the same. Before, I couldn't really lose weight, and if I lost something, I didn't really see the effect. So why should I continue keeping diet? And she managed to do it afterwards. So she managed to reduce the volume also on the tummy. But unfortunately, it doesn't work in all patients. So this patient, 103 kilo during at the consultation. Then when we started surgery, she had increased her weight, and then, well, between the surgeries, it went down, it went up again, and at the end, she, well, still had 3 kilos more than during consultation, but she had lost a little bit since the first surgery. She was still totally free of complaints, and she didn't need any compression, but she didn't really manage to lose weight. And if you have a critical look up here, she did increase. So it doesn't really work in all patients that they manage to lose weight then due to well, during or after liposuction. But the body proportions change, and this woman said, well, now after surgery, my belly is much more visible, but if you measure it, she has also lost some weight here and some circumference, but because the legs are now much slimmer, the tummy looks a bit different. Also here, 13 liters of fat I removed on the legs, and she came and said, you know what, my legs are good, but now my tummy has really increased in size. And well, if you put a line here, it really looks like, yeah, your tummy is bigger. But then I measured her in the waistline. I know she had 3 centimeters less. So the subjective feeling of the patients after surgery doesn't always equal what we objectively then find. So of course, for the patient as such, the tummy feels or looks a bit bigger because the leg is slimmer. So it is the changes of the body proportions which makes the difference. But we also have patients who increase clearly their weight after surgery. This was a lady before surgery, before the second surgery, and on the day after surgery. So we reduced 5.6 liters of fat, and she first increased her weight, and then she came again to our clinic after 6 years, and unfortunately she gained 15 kilos of weight. And here you can clearly see the legs have increased a little bit, but the much bigger volume is up here on the tummy. So she clearly increased her weight here. And this is what patients always ask when they come to consultation. They ask, well, I've heard that after liposuction of the legs, everything goes into the tummy and the arms. No, this is not really correct. The fat volume of the legs, or the amount of fat cells, is reduced after liposuction. So if patients gain weight, there are less cells available which can increase in size. So of course there can be still a slight increase of volume on the legs. But for example, on the tummy, or if we haven't performed liposuction on the arms, there's still the original amount of fat cells there. So on the tummy and the upper arms, there is a normal increase, and on the legs, there is a less increase. So the patients have the impression now everything is going into the tummy. So it is not, I'm getting more fat on the tummy, it's just I'm increasing volume in a normal way on the tummy, but it looks or it feels more because the legs remain slimmer. But this is a problem. So if, as I said before, adiposity is a big issue in lipedema, and if patients don't find a way to deal with it, gaining weight has a negative impact on the result of the surgery and also on lipedema. A big question issue is always what does pregnancy do with lipedema? I always say, well, we can't predict what it does to the patient. It is a possibility due to the hormonal changes during pregnancy and breastfeeding that there may be some changes, but it doesn't have to be. I really can't, unfortunately, tell you any numbers. We have some patients who come and say, no, well, I've had 2 kids and it didn't change anything. Others say, well, yes, during or after pregnancy, the lipedema increased and the pain became stronger. This is the example of a patient who underwent surgery of her lipedema. She already had two children and said, yes, with the pregnancies, the legs became bigger in volume, and also the complaints increased. So I performed 3 liposuctions, and then she became pregnant again. She said it wasn't planned, but she was quite happy, and she presented herself 10 weeks after delivery, and we were both really happy that there was no big changes in the legs. But I can't tell, was this no changes in the legs due to our surgery, or perhaps would in this 3rd pregnancy it wouldn't have made a change anyway. We can't tell, because we always perform liposuction on both legs. So I always have to smile, but it would be interesting just to perform a surgery on one leg and then, well, let the patient become pregnant and see what is the difference. Now, this is unethical. Nobody's going to do this, but this would really help us to say, okay, was this effect due to the surgery, or was it just that in the 3rd surgery it wouldn't have come to a change? So if patients ask me, well, I'm unsure, should I become pregnant? I always say, lipedema is nothing which should keep you from getting pregnant if you want to have children, but you just have to keep an eye on the legs and be alert. And I would wear compression garments regularly. It doesn't have to be that lipedema changes. And what the patient herself can do is try not to gain too much weight, because the problem we often see is that if a patient gains like 20 to 30 kilos during and after pregnancy, this of course has an impact. And I think this increase of weight has a stronger impact perhaps than the changes of the hormonal changes. So to summarize, liposuction is, if you use the right devices, and it is a very safe and effective procedure, and it has really significantly expanded the therapeutic spectrum in lipedema. We can change quite a lot of things, but we can't change everything, and it is really necessary to talk with the patient about what limitations do we have, what can we achieve, and what can't we achieve. But we can really clearly further improve quality of life, and this was not imaginable in former times when we didn't have the liposuction yet. So I hope I could give you some informations. I could have told you much more, but time is running out. So I'll gladly let me get this. Stop presenting. Is it? Okay. Yeah. Okay. There I am back again. So thank you for listening. And I hope there was some interesting things I could tell you.
That was wonderful, Dr. Ilka. Thank you so much. You won't be surprised to know that we have a whole host of questions from people. Okay. So if it's okay, I'd like to start with a few, what I hope are kind of like shorter, quick fire questions, we would call them in English, and then we'll go into some slightly longer ones. So starting with those, do you have a weight limit in your clinic? And do you only operate on stage 1 and stage 2 patients?
Well, we mainly have stage 1 and stage 2. We sometimes have a beginning stage 3, but if in stage 3, often the amounts of fat and skin are so big that we get problems in taking care of the patients. So we really have to limitate it. Yes, so we mainly have stage 1 and stage 2. Yeah.
That's perfect.
And with the weight, you can't say we can't perform surgery over 120 kilos. It depends on the size of the patient. It depends on the distribution of the fat. So this is really an individual question.
Okay, do you have a hard weight limit in terms of like the equipment that you use at the table in your clinic?
No. I've performed surgery on a 185 tall lady. She was 140 kilos, but she was so well proportioned that it was possible. But of course, if someone with 160 weighs 120 and he has all the volume on the tummy, this is not possible. So it is, you can't say not possible over 100. No, it depends on the the distribution and the proportion.
Perfect. Is age the same? Do you have an age limit, or do you focus more on things like their overall health?
Yeah, it's more the overall health, and of course, how mobile is the patient. I think we've had our oldest one was 72, 73, something like this. But of course, the older you get, the more general problems are, like heart problems, and then you have to be critical. Is it possible to perform a surgery still or not?
Perfect. So you talked about treating some patients who maybe were stage 3 who had larger volumes. You don't use things like Renuvian, J-plasma, or other lasers that some doctors use for skin retraction. Do you? Number one, can I just check that's the case? You don't do any additional?
No, we don't. We just have the power assisted, the vibrating cannulas, because we think that you can achieve quite a good skin retraction. Of course, as I showed you, we have limitations, but I think in this one case with this really soft and excess tissue, I think also with the laser, this wouldn't have improved anything. So there are some cases where you just have to think about the skin tuck. But you have to decide, this is always very critical, because skin tuck means you cut diagonal over the lymph vessels.
Perfect, thank you. Valeria, I'll hand over to you for the next question.
Yes, I have actually a more general question. It's about classification in lipedema, because we all get to know about classification criteria from you in person, actually. So what do you think about revision of these criteria, including pain and mobility issues? I mean, staging and other issues concerning this specific.
Well, as I said, the staging just takes in account part of the complaints. It's just the fat volume, and it's just the consistency of the fat volume. It doesn't say anything about pain. So if you really want to assess everything, then a really good staging would have to include also the complaints, the amount of edema and the pain. But this, of course, is going to be really difficult to put this all into one classification. And well, regarding the name of the disease, lipedema, yes, I can understand that other colleagues think, is it the right name? We say it too, because the edema is not the central point. I mean, the fat and the pain, this is what makes a lipedema a lipedema, and the edema as such is not the strongest. So I can understand that Dr. Cornelia, for example, says, okay, he calls it a lipohypertrophia dolorosa because it includes the pain. But yeah, I think it's good that we talk about this and we perhaps think about alternatives, but it's just the name. So I don't know if it's worthwhile doing so much effort in discussing what is the right name for something. Is it not better to find a good way to treat it? But yes, this is the limitation of the name of the staging.
Thank you.
Thanks, Valeria. We had a person saying, would you have any concerns about operating on somebody who had fibromyalgia?
This is difficult. I've had some patients who were diagnosed with both of them, but it is really difficult because fibromyalgia has also the sensitive pressure points in the same areas as the lipedema has. So it's difficult to predict, okay, what would a surgery change? are the complaints in the legs more due to lipedema, or is it more the fibromyalgia? And also, it is always a question, what will a surgery, an irritation of tissue perhaps do with a fibromyalgia? I had one patient I performed surgery on who had the diagnosis of a fibromyalgia, and I was not really convinced it was one. And she had an improvement. But others, which had really a clear fibromyalgia, also with pain on the trunk, I haven't performed a surgery on. So this is really the question. This would be a thing you individually would have to see. It was the same if someone has itching on the head and you have lice and you have flea, you never can tell, okay, what makes more the itching. And so it's the same with the fibromyalgia and the lipedema.
Yes. So there's a number of different conditions that people can have that you would probably discuss beforehand.
Mm-hmm.
Something else we were asked about was what if the person has a large birthmark, for example, on their leg, or perhaps other vascular issues.
Well, if they are just
The English
superficial in the
birthmark is like a port wine stain. The German for that has just escaped
yeah,
me.
and well, if it's just a port wine stain or something superficial, it doesn't change anything of the procedure. But sometimes these marks can be associated with findings in the veins. Then of course we would have to check the veins first to see will there be any surprise when we start doing the liposuction. But if it's just a superficial thing, then it doesn't have an impact on surgery. No.
Thank you. Valeria?
Yes, I have an interesting question. A lot of people complain about an increase of the tummy after treating legs and arms and without having bad nutritional habits or even on continuous keto diet. Can you explain this phenomenon?
Yeah, well, this is what I tried to explain a little bit. On the tummy is still the original amount of fat cells, so they will still react to what you're eating and how your living habits are. And it is known that over 50% of the lipedema patients have an overweight problem. And just by doing the liposuction, we don't solve this problem. So on the area here, the tummy is the area which we can influence more by calories. So this will still change if they don't find a way to deal with this. So this is the problem, and this is what I tried to show with the pictures, that when we reduce the legs, of course the tummy looks bigger, and there the original number of fat cells can increase in a normal way, and the leg just increases slightly. So we have this change, and I've seen no one with a bigger tummy afterwards who didn't gain weight. So it's always usually a factor of gaining weight, and of course it is visible then in the tummy.
Okay, thank you.
Another two-part question. What particular additional precautions or advice do you give to patients coming internationally for surgery? And if I can put the second part there as well, how many months after surgery do you think people have their final results? Because they will go home, they'll have some more swelling. How do they know when they are finished?
Well, the first finish is already after 8 weeks.
Yeah.
Then it's quite healed and quite good, but still there are smaller changes. So really, if you want to evaluate also the still remaining swelling tendency, you would have to wait for half a year. So after, like for example, surgery of the lower legs, which have a stronger swelling tendency after surgery, we wait for at least half a year, and then it's usually the end of the changes, so you could evaluate how much is still left over. But the biggest changes are during the first 6 to 8 weeks. And if someone comes internationally, I mean, we offer that they send us like questionnaires completed and photos so we can have a look, and we can already discuss several things beforehand. But if they come to surgery and they have a long distance flight, I mean, not to England, this is just an hour, this is okay, but like from further on, then they have to stay here or in Europe or in Germany for a week till they should go on a long distance flight because of the thrombosis risk.
Perfect. And do you recommend they have MLD during that period while they're still?
Well, if we offer that we could organize something. It helps surely, because the swelling starts after, well, day 6 to 7, and then it's quite good if you have it.
Perfect. Valeria, back to you. Thank you.
Yes, I have a final question about do you have any personal tips or advice to add to the ones you asked for pregnant women, in addition to what you said?
No, not really. It's just keep an eye on your body and on your legs. Wear the compression garment. Even if you don't wear it regularly beforehand, I would do so. But pregnancy as such can make more swelling or lesser swelling, so you never know. And like exercising in water, doing aqua gymnastics is also possible when you're pregnant. So this is really a good thing to do during pregnancy. And a big issue is try not to gain too much weight, because this is what I think is the biggest problem. If someone gains like 20, 30 kilos and can't get rid of it later on, this of course also has an influence on the legs. So this would be good if you find a way. But as I said, if there's some genetical risk for overweight, it is really difficult, and it is a fight, a long life fight.
We had an extra question on pregnancy. Do you think that giving birth by a cesarean section as opposed to a normal vaginal birth makes any difference to people's lipedema progression?
I really don't think so. Of course, a cesarean section is you make a cut and you also cut like lymph vessels. But if this has a really effect on the swelling, let me think. No, the patients I see after a cesarean section, they don't have more swelling on the legs. So no, I don't think it has an effect. No.
That's perfect. Thank you, because the hormonal changes in pregnancy are such big questions for many of our members. And speaking as an aqua exercise fan, thank you so much for plugging that really good messaging.
No, this is so important, because it's something you do actively, and we have so many patients who say, well, I go to lymphatic drainage. Sure, it's nice to lay down and let someone else do it, but your active movement is much better.
Yeah, you're very welcome to come to one of our next conferences and join us in the field, because we do aqua exercise. That's something that's very important to us. We could ask you questions, I think, until the sun goes down and we go on all night.
Yes.
I think we've covered most of the key topics and questions that we had from people, and it's been really wonderful to hear your realistic advice and your honest assessment for people, because I think it really helps people to be able to take away some of that thinking they can do if they're considering having liposuction, to think about, how will it affect me? How can I do the best preparation for myself? And how do I come to a realistic mindset about what my outcomes would be? So I think we've had a really great discussion there, and we really appreciate it. We are doing other webinars, aren't we, Valeria? Because we just can't stop ourselves. Did you want to just run through what we've got coming up?
Yes, next week on the 12th, we have another webinar with Dr. Burgos de la Obra, speaking about intermediate and advanced stage lipedema surgery. So we can speak again about surgery. Today we had the point of view of early stage lipedema surgery, and then we will discuss about advanced and intermediate stage. Then we have the very last event of our super extended long lipedema month on the 20th of July, in which we were going to present the manifesto of lipedema with the help of other lipedema association, and we will have Dr. Michelini speaking about our future plans.
So thank you ever so much, Dr. Mie-Volrath, and I hope everybody who's joined us tonight feels more confident going forward about what their surgical options and path could be. So thank you very much from all
Well,
of us.
I say thank you. It was my pleasure being part of this, and I really gladly did it. So thank you.
Excellent. Well, I look forward to seeing you in a swimming pool working out with all of us.
I will participate. Yeah.
I've been to the swimming pool in Lubeck. It's freezing.
It's
Come to Italy, do those stuff because it's so hot in there.
It's warmer, yeah.
Thank you very much, Doctor. It was super
welcome.
interesting and very important for our first stage lipedema patients who badly need information about surgery and lipedema management. So thank you very much for staying with us.
Yeah, I say thank you for having me. It was my pleasure.
Perfect.
Thank
We'll see you again soon.
Okay.
So to the next webinar. Bye-bye, everyone.
Bye.
Bye, everybody.